if I find somebody down, I can say, hey Siri, call 911.
Calling emergency services.
But don't really do it. Well, I appreciate the opportunity to come here and talk to you about CPR because it's something that I'm pretty passionate about. I feel very strongly about because it is something that we can actually make a difference in a very short amount of time. And whether we do CPR or not in the right moment makes a difference between life and death. So they're very simple skills. By the time you're done tonight, you'll be able to do CPR. You just won't have a certification because we don't have time to cover everything that's required. But we will teach you the basics of how to do compressions, how to artificially breathe for somebody, how to recognize the signs and symptoms, how to clear choking, how to do CPR on infants and children, all these things. And hopefully you'll have at least enough confidence that you will be able to do that if the need arises. Well, the reality is that in the United States, the #1 killer in the United States is heart disease. It kills more people than all cancers and trauma combined. Because when somebody collapses and they're in sudden cardiac arrest, usually you have just a matter of minutes to intervene before the damage is irreversible or they cannot survive that. That's called hands-only CPR. The first thing I want to do is just talk a little bit about some anatomy, how the heart works, which will help us to understand the importance of doing compressions. So there's a couple of things that are very unique about the heart, about the muscle of the heart, which all the heart is a big muscle. That's unique about the heart that no other muscle or no other part of the body can make a claim to. One of them is that the heart generates its own electricity. That means it doesn't need an impulse from the brain until the heart muscle runs out of oxygen. That's one of the reasons that heart transplants are so successful. If they can remove the heart and put it in an oxygen-rich environment, the heart will continue to do its job until it runs out of oxygen because it creates its own electricity. The only thing the brain does is make it beat faster or slower, or maybe a little bit stronger. But short of that, the heart's just going to continue to beat its normal little regular rhythm until it runs out of oxygen. So that's one thing that's very unique about the heart. And we'll talk about why that's important in just a minute and why that'll make sense. The other thing is all of the tissue in our body gets oxygen and nutrients when our heart is squeezing. So when it's pushing blood, and when it's pushing that blood, it pushes the blood down to the tips of our fingers, the tips of our toes, our nose, all the different tissue and cells in our body. The heart is the exception. The heart is the only muscle in the body that gets its oxygen and nutrients when it's relaxing. And if you think about it, that makes sense. To try to give nutrients when it's squeezing and working, not going to be real effective. So when the heart is relaxed, there's a little valve that opens up and blood just kind of passively flows. So it's not under a lot of pressure because it's passive. So it just kind of bathes the heart. And as long as everything is working good, that process continues to go on. Well, heart disease, and the reason that people have sudden cardiac death, what happens is that over time, our diets, we start to build up some cholesterol, we start to build up some clots, we start to build up some nasty things in our vessels, and our vessels get stiff. And when they get stiff, then they don't flex very good. Well, that builds up in the heart, and so then you get this buildup until at such a point that something breaks loose and it clogs that artery in the heart, clogs those vessels. And once it clogs, blood can no longer flow. It gets stopped there, and especially because it's not under a whole lot of pressure like the rest of the body. When the heart is contracting, the heart only gets its nutrients when it's relaxing. So there's not a lot of pressure. So as soon as you start to get a blockage in those arteries, blood stops flowing. Well, if people develop these clots slowly over time, then our heart's pretty smart. Anybody ever seen the movie The Titanic? Okay, and the song, The Heart, I would sing it for you, but then you'd all be running out of here. But the heart will go on and on, right? Well, the heart will. The heart wants to find a way to live. And so when it starts to block, it'll start to develop some, it's called collateral circulation that finds its way around that blockage. And so people that have clots that develop over a long period of time, they usually fare better in cardiac arrest problems or in heart attack problems than, say, somebody that the reason the heart attack happens is because a clot broke loose somewhere else and then traveled into that artery and blocked it suddenly. They have not had time to develop that circulation. And so these people have a tendency to go into sudden cardiac arrest very quickly. And when that happens, when the heart, and the number one cause of what we call sudden cardiac arrest is a rhythm. Normally the heart beats from the top of the heart down to the bottom, just very rhythmically, makes the heart squeeze, pushes the blood forward, everything's good. Well, when the muscle lacks some oxygen, then basically the heart muscle just kind of has a seizure. It's called ventricular fibrillation. And so the heart kind of sits right here in the middle of our chest, primarily to the left a little bit, but some of the bigger vessels are kind of right in the center of the chest. And it just beats rhythmically and moves that fluid around, the blood around. But when we have sudden cardiac death, what happens? The number one cause of that is a rhythm called ventricular fibrillation. And what ventricular fibrillation does is it's like the heart having a seizure. There's so many areas in the heart that fire off electricity, and the area that fires off the most is the key. So it overrules the other parts of the heart that normally maintain that. And as a result, the heart just basically has a seizure, it's just quivering. And the electricity is not strong enough to squeeze the heart and push blood forward. So as soon as that happens, people, and what you may end up seeing someday, or what we see in healthcare, is somebody says, man, I don't feel very good. And all of a sudden they just kind of get lightheaded and boom, they fall over. Well, that's because their heart is stopped. It's quivering, it's not pumping blood. And as soon as it stops pumping blood, now there's no circulation to the rest of the body, so the body shuts down. The reason that that's important to understand is the goal of CPR is to push on the chest and squeeze the heart artificially. We are squeezing the heart to move that blood around. And that ventricular fibrillation, nothing fixes that except a defibrillator. When you see them on the TV, put those pads on it. Clear, and they shock them and their body jerks. That's really the only thing that'll fix it. We have drugs that'll help to fix that, but the only thing that truly fixes that is a defibrillator. Well, if we don't have one, we got to do something to buy them time. And what we do is compressions. Because our body, you and I, and kids have more, and people that are healthy have more, but you and I have about a 4 to 6 or maybe 8 minute reserve of oxygen that's just stored in our tissue that we periodically replace, but it's just stored there for such an emergency. So if I was to just suddenly fall over right now and okay, well, I have all this oxygen reserve in my body that can keep my tissue alive, keep my body alive. The thing is, we got to get it circulated. So the only way to do that is compressions. Compression circulates that oxygen. Now, we're going to teach you how to do the mouth-to-mouth, because then we are replacing that oxygen so that buys them more time. And that's important because when you live somewhere maybe a little bit further away, if you call the ambulance, it's going to take a minimum of 10 minutes for them to get there. We have what we like to call saves. You have somebody goes in cardiac arrest, you get them back. We like those saves. The vast majority of saves only happen because somebody did good CPR before we got there. It had nothing to do with us. If they didn't do that, we would not have a patient. And a lot of people say, I don't know if I could do that. I don't know if I could do that. And it freaks me out. And I'm not big enough. I can't push on the chest. Well, in the heat of the moment, especially if it's somebody you know, I promise you, you'll do it. What a defibrillator does, I told you that it just creates that, our heart creates its own electricity, but then there's those parts that get irritated because they're not getting oxygen, so they just fire off and the heart just quivers. Well, a defibrillator, which is those pads you see, and we're going to show you how to use an automated one. What a defibrillator does is it sends a shock through the heart muscle that resets that pacemaker, knocks out those sites that are irritated, so that the regular pacemakers of the heart can then take over again and do its job. And so the faster that we can do that, the better the outcome is. But if we don't have access to that, then we got to do compressions to buy him time. So Cade is he's my partner on the ambulance, and he's also one of the paramedic students. And all of my students know I have this great, for me it's great, I mean I say that tongue in cheek. We like acronyms in healthcare. So I have an acronym that I've developed. When I do my doctoral thesis, I'm going to incorporate it somehow. Just kidding. But this acronym is ADPNAP. ADPNAP. A dead provider is not a therapeutic provider. And what that means is, if you do something, if you have to rescue somebody, if you have to help somebody, but you do something that gets you hurt or dead, you have done nobody any good, you haven't done yourself any good, you haven't done your family any good. So the number one priority in any rescue situation, it's not to be selfish, but it's to be realistic. The number one priority is always you. So you do not want to do something that's going to get you hurt or get you injured or get you killed, even worse. So the first thing we always teach everybody is, when you see somebody that's down, somebody that seems to be unresponsive, stop. Before you approach them, stop. Look around. Make sure that there's not a downed power line, that there's not some carbon monoxide, that there's not something that is going to harm you that would make it impossible for you to rescue them, and then you would then have to be rescued. The number one thing that I want to emphasize tonight, if you don't get anything else out of this, here, please keep yourself safe. Don't do anything that's going to get you harmed or get you hurt to try to rescue somebody. Okay, so number one it's just make sure that you're safe. Then what happens is, let's say that you walk in and you find this person lying down. Okay? And the other thing about rescuing somebody, it is a touchy-feely sport. It is not, hey, are you okay? Because how many of you sleep pretty soundly? If somebody walks into a room and says, are you okay? And you're just sleeping, I know a lot of people that wouldn't wake up. I know a lot of people that if I said, are you okay? And I just went like that, just barely touched them, they're not going to wake up. Okay? So rescue is touchy-feely. We got to get our hands in there. Okay? And so you find somebody that's down that doesn't seem to be doing well. Well, we need to intervene. And so what we do is we say, sir, are you okay? Are you okay? And then we get down and we shake them. Okay? If they do not respond, and I'm not saying shake them and go like this, wake up, pound their head, right? But you want to just shake them a little bit. If they don't respond, then the next thing you need to do, especially with adults, because the number one cause of sudden cardiac arrest in adults is that heart rhythm. So we got to get a defibrillator coming. Next thing you got to do is just find somebody, point to somebody, and do not say, help, somebody call 911, because we live, unfortunately, in a society that everybody has one of these. But if you look at YouTube, you realize that most people don't use it for that. If there's an emergency, what are they doing? They're videoing it. They want to be the next YouTube sensation. It's absolutely ignorant to me, but it's the absolute truth. So if you have to get some help, this is what I tell you. You got to be a little bit assertive. You call 911 and tell me when you're done. Don't just say somebody do it. You point somebody out. That way you know. Here's another advantage of our technology, though. Okay? So another advantage. If I find somebody down, I can say, hey, Siri, call 911.
Calling emergency
But
services.
don't really do it. 911 gets called, and it automatically turns on a GPS locator. And with our enhanced 911 system, they can find me within 30 feet of where I am. So if they can get within 30 feet, I'm pretty sure they're going to find me. The other thing that it does is it turns my speaker on. So I could say what I just said without turning that on, put it on the ground and start doing CPR, and I can talk to them while they're doing that. Okay, while I'm doing my thing. There's another way too. On the Apple products, this home button, if I hit it 5 times. Stop. So I don't like that it alarms, because it used to do it silently. So if somebody was bothering you, if something dangerous was happening, you could push that button, it would call 911, but nobody would ever know. So you could stand there and say, please, sir, just leave me alone, or hey, stop, and you could talk and they could hear exactly where you are. It gives them a GPS location. But it's another way that you can call 911, and the same thing. Turns on your GPS and turns on your speaker so you can put the phone down and then do what you have to do. So if you don't have somebody to point to and you have a cell phone, that's some things you can also do to make sure you have emergency services. Then the next thing that you want to do is you want to check and see if they're unresponsive, and check and see if they have a pulse. And what we say is, if you're not sure, and the reality is, if they're not responsive, we want the general public to just start doing compressions. But some people freak out about that. Like, what if their heart is beating? Well, if they're unresponsive and their heart is beating even a little bit, you're not going to hurt them. You're going to, and you'll find out pretty soon if it is actually beating. But what happens is that we used to teach people, okay, we want you to check the pulse for the general public, and they would go, oh, I think I feel a pulse, so they would do nothing. When in reality, they weren't feeling a pulse. What they were feeling is they're nervous, they're scared, right? Okay? And so now we really encourage you, if you're not sure, just start compressions, okay? But if you really want to check, and I always have people say, can you teach me that anyway? So we do, okay? What you want to do is you want to take your fingers, and everybody can do this to themselves, and you find your little Adam's apple, your little bobber. You swallow, it goes up and down. And if I'm using my left hand, I'm going to my left side. If I'm using my right hand, I'm going to my right. So we don't ever go away, because what happens is we drop our thumb, and at the end of our thumb, we have an artery, a pretty big artery. So if I'm touching my skin with that, I'm going to feel my pulse. So we move away so that our thumb is never touching. So if I'm on the patient's right side, I'm going to go to their right side. If I'm on the patient's left side, I'm going to go to the patient's left side. We always go toward us, not away. Okay? So then you're going to just find right here, the angle of your jaw, there's a little groove underneath your jaw. And if you put your fingers there, don't push hard, you can feel your pulse. We want you to feel that, but you feel it for no longer. The absolute longest is 10 seconds. Okay? And if you don't feel or you're not sure, you feel a pulse. And at the same time you're checking that, you're watching your chest to see if it rises, see if there's breathing. Okay? And there's only one caveat to that. When somebody goes into cardiac arrest, they do something called, many people do something initially called agonal breathing. Agonal breathing is ineffective. It's not producing a breath. It's not producing oxygen. But people see it and they go, oh, they're breathing, so they must be okay. And agonal breathing looks something like this. I'm going to kind of exaggerate it, but it's almost like a fish out of water. You ever seen a fish out of water or seen videos of the fish goes? So what happens is somebody, when they're agonal breathing, you'll see it's their body's last-ditch effort to try to generate some breathing, but it's completely ineffective. Okay, and so you'll see them, they'll go. And you'll see their chest rise, but you'll hear no air movement because there's not. So if you see that, they're not breathing, we intervene. Don't think that that's normal and that I don't have to do anything. It's ineffective breathing, we need to intervene, okay? So that's kind of the gist of the initial assessment. Keep yourself safe. Walk up, are you okay, are you okay? If they don't respond, you call 911, tell me when you're done, or you call it if you have to, okay? Call it on your phone, put it down, and then you check their responsiveness, you check the pulse and breathing, and as soon as you determine that they're not breathing, now we start compression. So I'm gonna let Cade now teach us how to do the compressions part.
So when you're doing compressions, you want to put the base of your palm, put one palm on top of the other, and you're gonna line up the nipples, okay? Or where they should be. Sometimes they're not anatomically correct. So you want to, on these dummies, you can find where they are. You're gonna put one hand, preferably your dominant hand. You're gonna put it down, your other one on top of it, right in the middle on your sternum. And you're gonna push. And if you're the first one to do CPR, you'll feel like you're breaking those ribs. And it's not the actual ribs, there's cartilage that's connecting. I've done it twice and it feels weird. It really does. You should be saving somebody and you feel like you're breaking them. But it's normal. Do it once or twice, get over it. You'll move past it, they won't be breaking you anymore. I'm gonna do it about a depth of 2 inches, okay? And now everybody's gonna be different, okay? So do it effectively. You wanna push all the way down 2 inches and then let it completely recoil, okay? So like Randy talked about, what we're trying to do is squeeze that heart. If you're going down and not coming up, it's like trying to flush a toilet consistent. That heart's not gonna fill up with blood and you're not gonna get on the rest of the compressions, you're not going to get any blood into the heart to pump and beat around, okay? So doing all that, you've checked, they're not responsive, 911, you're going to find your landmarks and you're going to start. So for lay people, you're just going to be doing it until somebody else shows up. If it's me and Zane working, I'm going to go 2 minutes, then he's going to go 2 minutes, and we're just going to cycle. And most people, they want to use their hands and their elbows, and you're going to get tired after about 10 or 20. Okay, but if you lock your elbows in and you use your back,
and your shoulders are straight over, not off to the side, right?
You can actually do it a lot longer. And then you're going to go 2 minutes and switch. And so you don't want to be like, okay, my 2 minutes is up. Zane, you come get ready and you start. Okay, it should be, come here, Zane. 1, 2, 3. Perfect. And that's how you guys want to be switching with
When
somebody.
you switch, it should absolutely never take longer than 10 seconds. Okay? And the reasoning is when we're doing compressions, when your heart's beating, it has pressure inside the arteries. When it stops beating, the pressure goes away. So if you take too long to transition, that pressure goes away very quickly. And then on average, it takes 6 to 8 compressions just to get enough pressure to push that blood into the tissue again. So you've spent almost a third of your compressions just building that up again. But if you do it immediately, so that there's very little, then you keep that pressure stays built up. So we got to stay right on those compressions as fast as possible.
If they start fighting you and telling you to stop, it hurts, then you should stop.
Okay.
Sometimes though, you might do compressions early enough and effective enough that it will bring them back. And as soon as you stop, they'll go back out. And at that point, you just tell them, sorry. It's what's keeping you alive.
Because what's happening, you're doing compressions, you're circulating oxygen, and it's going to their brain. So we have done compressions just this weekend. Somebody woke up as we were doing compression, started slapping my hand, and at first I was like, oh my gosh, we're getting some cardiac induced or some compression induced consciousness, and it'll happen. As soon as you stop, then you're not circulating oxygen anymore, and they become unresponsive. So sometimes it's kind of eerie when somebody reaches up and grabs your hand when you're doing compression. You're like, whoa.
The best place to do compressions is on the ground. Okay? So if they're up higher or something, there's several of you in here that might not be able to reach the table. Okay? My wife, she works in the ER, she's very short. She can't do compressions, even with the bed on its lowest, without a stool. If you try to do it on a bed, you're going to squish the bed, not the person. And we've showed up a lot of times, people are doing compressions on their loved one on the bed. They say they've been doing it for 5 minutes, but they really haven't been doing anything for 5 minutes because they're just pushing the bed down. Okay, so get them somewhere where it's, pull them to the ground. Well, what if I hurt them? They bump their head, like Brent said, they're dead. Okay, it can't get much worse than that. The headache's really not their problem at that point. Okay, so get them down low where you can reach. It's a whole lot easier to do it on your knees than it is standing up, tippy-toeing, or anything like that. So pull them to the ground and then start CPR.
They found it to be way more effective and better outcomes, even for pre-hospital people, and so this is now our policy, this is now our protocol. You find somebody in cardiac arrest, you do 200 compressions before you do anything else. We don't defibrillate them, we don't do anything. We do 200 compressions before we think about anything else. Because what we're trying to do is circulate that oxygen, get the heart kind of primed, so that when we shock it, now it's like priming the pump. And there's way better outcomes by doing that. So 100 to 120, or like Kate said, if you're not going to breathe, then you just keep doing compressions continuously until somebody else shows up, or until if you start to get so tired that you can't do it.
And if somebody's there, rotate out. Okay, don't just think, oh, I'm going to be the hero, I'm going to keep doing it. After about 2 or 3 minutes, you're going to run out of energy. You're not going to be doing effective compressions. Let somebody else come in and do it while you rest, and then switch back.
If the person next to you doesn't know CPR,
Tell them to watch.
You can coach them.
Watch.
Just push hard, push fast, right in the center of the chest. That's all you got to do.
And if you call any dispatch, any 911 number, the dispatchers are trained in CPR and trained to teach you over the phone how to do it. They should be able to, like we've just been telling you, check and see if there's a pulse, see if they're breathing. If not, find the center of their chest, put your hands one on top of another, and push hard and fast. About 100 to 120. Where the nipples are or supposed to be, find that bone. If you don't feel it break, you're not doing it right, or you're not doing it in the right spot.
Pushing on the center of the chest. Okay? But what we don't want when you're doing that is your hand to bounce like this. Okay? Your hand should always maintain contact with the chest. What happens when you bounce is that we have a tendency then to move over to the ribs rather than stay in the sternum. And when we push on the ribs, especially in the center, we will break the ribs, and then we have a greater chance of pushing those ribs into the lung or to the heart. So we want to avoid that. If we're pushing in the center of the chest on the sternum, there's a very small likelihood of doing that. So it's really important that when you're doing compressions, that your hand is not bouncing like this. It stays in contact with the chest the entire time that you're doing that, but you're allowing that recoil. What that means is you're not pushing like this. And I saw that a couple times where they're going like this, but see how the chest is still caved in? It needs to come all the way up. If it doesn't come all the way up, there's not enough room for that blood to return to the heart. I just gave you in this little red pouch. It's a barrier device to help you breathe. Okay? Not help you breathe, but help you breathe for the patient. So I want to show you quickly how this works. Okay? So it'll be folded up inside your bag like this, and what you do is you just open this up, okay, like this, and you'll see this little blue thing right here, okay? You put this over there. I'll demonstrate right here, okay? And if you're not sure, you can look right here, and it'll give you the instructions. Now, in the heat of the moment, nobody reads. Yeah, who's going to read it, right? Okay. But what you do, okay, is you take this barrier device, and it's not going to work too good on these mannequins. Let me remove this. And this goes in the mouth. It's not going to work too good on this mannequin because the mouth doesn't open very well. Or if you can't do that, then you can just put it over like this. It's a little bit harder to do that way. Okay? But that goes over the mouth, and there's a little barrier in here, a little filter in there that keeps their air from coming back to you. So if they had some infectious disease, and if they were to vomit, which happens sometimes when doing compressions, it keeps it from coming back into your mouth. That's disgusting, I know, but it does happen. This is a great thing to put in your car, put it on your keychain if you want to, okay? But this goes in the mouth, okay, and it's not going to work. But you put it in their mouth, and then when you have to breathe for somebody, what you're doing is the tongue is attached to the mandible, the jaw, the lower bone. And what happens when somebody relaxes is that jaw relaxes and the tongue covers the airway, so you cannot breathe for them. So we have to move that out of the way. And the way we do that, we take our fingers and we pinch the nostrils, and then we take our hands that are down closer to the chest and we lift the jaw up. So we just pull the jaw forward. Okay, and if you try that on your mannequin, you can see you pull the jaw forward. If you do not do that, no matter how hard you try, you will not get air in their lungs. You have got to get that jaw up to move that tongue out of the way. Once you do that, then what you're going to do is you're going to seal the nose, and you're going to give 2 breaths. Okay, and think about how you breathe. Do you breathe like this? No, you don't. You breathe like this. So you're going to give breaths the same way. You're going to do 2 breaths. Each breath should take at least 1 second. And all you're looking for is the chest to rise. As soon as the chest rises, stop giving the breath. It is not, oh, I see the chest rise, so if it rises a little more is better. As soon as the chest rises, that means you've given them enough air into their lungs, so stop. Let the chest relax, and then give them another breath. Okay? And as soon as you see the chest rise, your job is done. That's what you've done. Okay? We recommend that you do not give breaths. You just do compressions till somebody else shows up. And that's why we say, as soon as you see the chest rise, stop. And if you're not seeing the chest rise, that means you have not opened their airway enough. So you need to reposition it and get that jaw forward. So we want to talk to you about, just show you how to use these, because every AED is universal. No matter who makes it, there's 4 steps. Okay, so the thing if you don't remember anything else about an AED, remember this: if you have to use it, turn it on. Because if you turn it on, it will tell you exactly what to do, and I'll show you. I'm not going to tell you anything else about this AED. I'm going to turn it on. I'm going to let you see how easy it is if you just follow the prompts. So the very first thing to do is always turn it on. After you turn it on, follow the prompts. So we're gonna do this. Okay? So the first thing to do, no matter who makes it, it's similar. The on button looks like this. This little O with the line, is it green? I'm colorblind, so that's green. Okay, so you push that.
Adult patient. If the patient is a child, press the child button. Remove clothing from the patient's chest. Remove packet and apply pads onto patient's bare skin.
So there's a picture on here that shows you where to put it. Put it on their skin.
Press pads firmly on touch the patient, analyzing heart rhythm. Do not touch the patient.
So now what it's doing is it's looking at the heart to see if it's something. Okay, so now it doesn't detect that there's a shock. So it'll tell you begin CPR. Now listen to this. What is that? That's how you do compressions, okay? And it'll tell you every 10, 20. So you know when you're doing, and here's the other thing. You turn it on and you never turn it off. Because every 2 minutes it'll tell you to switch compressors, and it'll analyze the rhythm again, and then it'll shock.
Press the child button. Remove clothing from the patient's chest.
Are those reusable?
Remove fat.
They are
and
not.
apply
These are
pads
because they're
on the
draining,
patient's
but the
bare skin.
ones that you would use from an AD are
Press
not.
pads firmly on skin. Press pads firmly on skin. Do not touch the patient.
gonna hold this up if it does
Analyzing
this.
heart rhythm. Do not touch the patient. Analyzing heart rhythm. Shock
There
advised.
we go. So
Do
when it
not
says
touch
that,
the patient. Everyone clear. Press the flashing
okay,
shock button.
so when it's time to shock, there are two things that will happen. You will hear that dee-doo, dee-doo, dee, and this button will flash. Okay, so that flashing button, it will not deliver the shot until you push that. When you do that,
Deliver.
you will notice that when you do that to somebody, they will jolt. That is normal. Okay, and now it'll tell you to start CPR. Okay, the reasoning behind that is it takes less electricity to deliver a shock to pediatrics to get the desired effect than it does adults. However, if there are no pediatric pads, it is perfectly acceptable to put adult pads on a pediatric. However, it is not acceptable to put pediatric pads on an adult because pediatric pads actually have a chip inside of it that tell the monitor to only deliver a small amount of energy. That energy will not be enough to restart an adult's heart. So it's perfectly acceptable to use adult pads on a pediatric. It is not acceptable to use pediatric pads on an adult because it will not deliver enough electricity to restart that heart. Okay? So a couple of things about the AED though. You will notice, and obviously you have to do it on bare chest. You can't put it on, over their shirt or anything like that. So a couple of things. Somebody asked the question. This is not meant to be derogatory. It's a fact. If you have some women or some men have very large breasts, a lot of breast tissue. When you're doing compressions, you just have to get your hand between it as best as you can. If you're putting the pads on, you would put the pad that goes up here on top of that, and you would just have to lift the breast, take the back of your hand, push the breast up, and put the other pad right underneath the breast. But some people, when you expose them, you will notice that it looks like a little deck of cards or a battery pack underneath their shoulder. It's under the skin, but you can see it poking out. That means that they have a pacemaker installed or an automatic internal defibrillator. And so if they have that, you see that, you want to put the pads under that, not over the top of it. Because when you deliver that shock, it's going to reset that battery. However, if they're really small, if they're in cardiac arrest, that obviously is not working, right? So if you don't have any other choice, you can put it over that. It'll fry the battery, and they'll just have to replace it. But obviously something's not going right. They're going to have to replace it anyway. That's okay. Just dry the chest off as best you can. If you can get them somewhere where it's covered, that's fine. But if they're in a little bit of water, it's not a big deal. We're worried about floating in water. We don't want that. All right, so let's talk a little bit about when it comes to kids, particularly like school age, nothing is different. Still pressing 2 inches, it's still 100 to 120 beats a minute, it's still allowing full chest recoil. There's one difference that we try to emphasize. For adults, it's almost always cardiac related. That's why they're in cardiac arrest. For children, it is almost never cardiac related. Children don't have heart problems. Okay, so the reason that kids go into cardiac arrest is almost always, 90% of the time, it is because they had a respiratory problem, they were not breathing well, so they did not get oxygen to the heart and finally quit. So it becomes a little more important for children that we provide some kind of ventilation. So a barrier device, but it's still not, if we'd rather you do compressions than do nothing, okay? But the idea is that kids sometimes need a little more oxygen. Here's the other thing that's awesome, though. Because kids are healthy usually, they usually have better oxygen reserves than the adults. So if we will simply just do compressions, we're going to utilize that oxygen reserve. But if you can, you're going to give breaths, and it's exactly the same way. There's no change. You're going to give 30 compressions, 2 breaths, 30 compressions, 2 breaths, 30 compressions, 2 breaths. CPR is really no different. The only change is that we put a little more emphasis on breathing. The compressions are the same, the ratio is the same, the depth is the same. So we're not going to really talk about kids because that's easy. But what we are going to talk about a little bit is infants, because infants, it is a little bit different. On adults, we check the pulse here. Well, kids have a tendency to have short, fat necks. And they have very big, engorged tongues. Okay? And so sometimes those structures can make the arteries here deeper in the neck and a little harder to find. So in kids, we check on what's called the brachial artery. And we all have one, but for infants, it's easier to find that. So the brachial artery is from the elbow to the armpit, and if you kind of flex right underneath that muscle, that's where it is, halfway between. So if you want to find that on yourself, okay, it's underneath that muscle, kind of halfway between the arm. Not up here, not over here. It's usually right here. You know, they need to be on the ground. Well, kids, if you need to put them up on a table or something that's firm, that's okay, because they're little. It'll work. But what we do is after we shake them, are you okay, are you okay, and we check a pulse, and there's no pulse and we don't see any breathing in their chest movement, then the way we do CPR on kids, there's two ways. You take your fingers and you put it right between the nipple line, and you're just going to push straight down. Now, how do you know if you're pushing deep enough? Well, kids' heads are big compared to the rest of their body, right? So you want their head to bob to the music. Watch this kid. If I'm not pushing deep enough, that head is not going to move. But if I'm pushing deep enough, that kid's going to be like, yeah, headbanger, right? That's, you're doing effective compressions. If you're pushing deep enough, that head is going to bob, okay? And you're going to do it the same way, 100 to 120 beats per minute. So you're just going to keep pushing and doing that, okay? When it's time to give breaths, if you don't have a barrier device and you're going to do it to a child, then that's fine. But what you do is you basically put your whole mouth over their whole mouth and nose. You cover both of them. And you lift that jaw and you breathe the same way. Now, kids' anatomies are a little bit different. And so on adults, we pull that jaw all the way forward. Well, with kids, we don't want it all the way forward because their airways are really flexible. And if we pull it too far forward, we can kink it. So we want to just pull it just not quite all the way forward. We do what's called the sniffing position. And if you think about it, when you sniff, you don't go like this. Hi, my name is Daphne. You're going to work for me today. It's not sniffing like this, right? It's more like this, with the nose kind of forward. And if we do that, then we're not going to get that jaw all the way forward. So we do the sniffing position, okay? And then it's very important with kids that you do just enough breath, a little puff, to get the chest rise. It's not like adult, because you're going to pop the lungs, okay? So it's a nice, steady breath, and it's a puff. If you have to take just barely a breath to make sure you do it like that, that's what you want to do, okay? If you don't get air in, you don't see the chest rise, then reposition the head and try it again. Because frequently, maybe you got it too far, or you're not the right way, so just reposition the head. If they have a pulse but they're not breathing, then you're just going to give one breath every 4 to 5 seconds, okay? You're just going to give breaths and then every now and then check to make sure they still have a pulse. Kids are little vacuum cleaners. Okay? They love to find things on the floor, right? So, you have a kid that's sitting in the high chair, or they're eating, and all of a sudden they go. Do we intervene if they're making sounds? We do not. And here's why. Kids, the reason our voices get or squeaky like that, maybe I finally reached puberty now. Okay, but the reason that kids that our voices get deeper as we get older is that when you're small, when you're an infant and little, the narrowest part of your airway is from the trachea down, so it's really small. So that makes our voices kind of squeaky. Okay, as we become adults, then that part becomes the widest part, and as a result, our voices get deeper. We're moving more air through there. We get these deeper voices. So the problem with that is when it comes to choking is that kids get something that's partially obstructing their airway, and it's in the biggest part of the airway. What do kids do when they get scared? Exactly. So you have a kid that's sitting in the high chair going, and you go, ah! And you grab them, and what do they just do to that airway obstruction? And it is now in the deepest, narrowest part of their airway, and it is a booger to get out. So if a child is got a partially occluded airway and you can still hear they're moving air, they're coughing, you encourage them to cough. Pick them up, come on, cough, but do not grab them and go, ah! Because they're going to inhale that right down their lungs, and now you're going to have a complete airway obstruction, okay? So you want to just encourage them to cough. Come on, just keep coughing. You can do it. Just be calm, okay, until it comes up. Or until all of a sudden, now they're flailing around, and all of a sudden they're going, no airflow, okay? Can you be conscious and not breathing? You can for a short time, and that's what will happen. They will remain conscious, they're flailing around, but you will not hear any airflow, okay? And it's the same with adults. They can be flailing around and conscious, but they will not have any airflow. So what you want to do is, if that happens and they no longer are moving air, then we do what's called the back blows and the chest thrusts. Sit down. Let things be your help. Let them be your guide. Sit down, support the child's head like this, point the head to the ground, and you're going to beat this child. Okay? Not really, okay? But you're going to take the palm of your hand and you're going to hit them between the shoulder blades, and it has to be firm. It's not, oh, let me brush you off. No, we got to be firm about it. It's, and you're going to do it 5 times. Then you're going to grab their head, support it, bring it around, and you're going to do 5 chest compressions. Then you're going to bring it around, 5 back blows, and then bring it around, and 5 chest thrusts till something happens. 1, that thing goes poop and pops out. 2, you turn them over and you look in their airway and you can see that it's in there. It just hasn't come out. Then you're just going to roll their head and then sweep it out. But be very careful. We never do blind finger sweeps in kids, because you get excited and you think, oh, is that something in there? You have to know it's there, because if it's not, and you stick your thumb in there or your pinky, you're going to push it further in their airway. So do not do blind finger sweeps. If you see something in there, turn their head sideways so it falls into their cheek, not back into their airway, and then you take your pinky, the smallest part, and you sweep it out of their mouth onto the floor. Okay? So it's either it pops out, you see it in the airway, or all of a sudden they become flaccid. So they're not flailing around anymore, they're just flaccid. What's happened? They're unconscious now, right? So now we just do CPR. That's all it is. Now we put them on a table, and we just start doing CPR. The only difference is, after every 30 compressions, we look in their airway to see if that's come out. What will happen often is that, think about it, if you're choking, are you relaxed? Pretty tense and worked up, right? Well, the kid's the same way. And all of a sudden they become unresponsive because they've lost oxygen to their brain, and so they become limp. And as we become limp, our airway relaxes, everything relaxes. So now you're doing compressions and you're pushing on them, and it'll make it easier for that to come out. So if it does, we want to look in there and make sure that we clear it out of there. And even if that happens, if you clear it out of there, sometimes you may have to do compressions for, a few minutes to get everything started and flowing again until they start to become conscious, okay? But the idea is, if they become unconscious, we simply go to CPR, give 30 compressions, 2 breaths, 30 compressions, 2 breaths. The only thing we do is we just look in their airway before we give breaths to make sure that thing has not come out.